Okay, I will be talking about implanting toric IOLs and the surgical pulse. As I mentioned earlier, depending on what your cutoff is, whether it's 1 diopter or 1.75, almost 30% of our patients would have about 1.75 diopters of unelastic medicine, which earlier was not addressed, or we tried using LRIs. Now we can use toric IOLs and correct it very accurately. So when your toricity, corneal toricity is over 1.25, ideally put in a toric IOL. Anything below that, 1 or lesser, LRIs would work very well. It's well known now and proven that the most accurate way of correcting pre-existing corneal astigmatism in a patient is using toric IOLs. But to get there, your postoperative refractive correction should be predictable, both in the spherical and the cylinder. There's no point in getting your toricity perfect and calculating with the rule, against the rule, undercorrecting, overcorrecting the cylinder, and ending up with a plus or minus 0.75 sphere, which just spoils the whole effect. So you should have perfect biometry, and you should be able to get perfect calculations every time. And to achieve these results, we should aim at achieving a 0.25 plus or minus. Most of us are around 0.75 plus or minus. To tighten ourselves and come down to 0.25 takes a little bit of effort. So first, before you go into putting in a toric IOL, you have to assess the astigmatism, both the amount of astigmatism and the axis. And as Ramesh said, you can choose different ways of doing it, but the simplest, most inexpensive way is to take your normal manual keratometer and use it as follows. You have the plus mark. The plus mark is more easy to align than the minus mark. If you look at these two plus and minus marks, one of the two is smaller, other one is bigger. The same applies to the minus mark also. So when you align the plus, it's much more easy to align. So now focus, get the plus in line, turn the drum till the plus gets perfectly aligned. Take the reading. That's going to be 1K, K1. Now turn the drum, turn your whole keratometer through 90 degrees, realign again, and get the plus aligned, return. You'll get the K2. The difference between the K1 and K2 is the astigmatism, and the two axes that you measure are brilliantly accurate, as you would get of a tomographer. So that again, you don't have to go for an automated instrument. Of course, automated instruments do make life easier and are very accurate, but you can get brilliantly good results using your normal manual keratometer. So after you put all this in, you're going to put all the material, all the data that you have. That is, you have your K1, you have your K2, you have the axial length. And you're going to put this into the toric calculator. Before you start entering into the toric calculator, choose the lens that you're going to put in and use the toric calculator software supplied by the manufacturer of that particular lens. Almost all manufacturers give us the toric calculator online. We just go in, enter the data. And this is one from Appasamy. And this is the way that the result will come. It will ask you to place the lens here at 175 degrees. This includes the surgically induced astigmatism, and the toric calculator also will sometimes tell you where to place your surgical incision. So what is the surgical techniques in a toric IOL? You need to accurately mark the axis 1. You have to place the lens in axis 2. You have to verify the placement 3. And 4, you have to readjust if necessary. And 5, if you don't forget, do not induce more than 0.2 diopters of surgically induced astigmatism. Make sure that your incision is perfect, is as nimble as possible, is as square as possible, and of the appropriate width and not too large to induce any astigmatism. If you have source to the Hoya eye trace, it makes the life much easier. This will do all the calculations, do the toric calculation, and also tell you where to place the lens. So most of the toric lenses will come in the single piece, every one of these come in a single piece design, and they would have a marking either as dots or as a straight line. These markings are usually made with laser, and they signify the axis in which the lens has to be placed. In a single piece lens, it would be essentially at the optic haptic junction. In the plate haptic lenses, it would be in the long axis of the lens. This is the design of the plate haptic, where it is the long axis, the line can be seen there. That's used for placing the lens in place. I'll skip this because this has been covered already by Dr. Teague. So procedure, identify Pre-op astigmatism, take accurate K readings. Topography is a big advantage. Eye trace is very useful. Accurate biometry, toric calculator are the steps to go. So now it comes to axis marking. We all know that the axis has to be marked in the sitting position. All of us use some kind of a freehand marking. It could be just a device that you can go and stick on the cornea with your hand trying to hold it horizontally. Or you could have one where the horizontality can be verified either by a free floating weight or by a spirit level or by an electronic device that tells you that the instrument that you're holding is being held horizontally. Perfectly fine. There are 3 lines here, all 3 are perfectly horizontal, but only one of them goes through the center of the pupil or center of the cornea or the visual axis. The other 2 are also 0, 180, but they are 1 millimeter up and 1 millimeter down. Tell me anyone here who can guarantee that 100 times out of 100 you get this marking freehand, irrespective of which instrument you use, whether it's electronic or the spirit level, that you will get this line through the center of the cornea. No way. I think quite a number of you put your hands up when Ramesh asked whether you're doing toric lenses. I'm going to ask you a question. Now, those of you doing toric lenses, when you put the lens in the bag, you rotate it, you find you can align one line and you can't align the next one. All of us have come through that. If you've done that, then that's what the mistake you've done. So that's what you've done. If you've done the marking there, one will otherwise will not align at all. So you're going to have at least 3 to 5 degrees off there straight away. So how to get over this? Only one way to do is this slit lamp marking. I'm a fan of this. I started off and I got 5 tips from Ramesh and I follow this 100% now. All you need to do if you want to mask is 0, 180, place your slit horizontal, place the patient on the slit lamp, put a wire speculum, put a drop of anesthetic, tell the patient look into the light, make sure that the slit cuts through the Purkinje image, the corneal Purkinje image. There's no way you'll make a mistake. The 0, 180 can be marked. You can actually mark whichever axis you want, because if you turn your slit lamp column, you'll find that there's a gradation there that tells you at 5 degrees where you're going. So if you take in between 5, you can get 2.5. You can get an accuracy of up to 2.5 degrees. You can turn it if you want to mark it at 135. Yes, you can do that. If you want to mark it at 45, you can. 65, everything is possible. Either you can do 0, 180 reference marking here or do the actual marking itself. I now do the actual marking. I do it on the cornea, make 2 small scratches. And these scratches would stay there, as Ramesh said, right through the surgery. They won't disappear. You can highlight them by putting in fluorescein or just marking on top of it with Japan blue. So that's my surgical marking technique, and I find that to be very useful. Surgical technique would be fine, long marking on the axis. The mark has to be fine, long, it has to come into the pupillary area. I'll explain to you why. It's very important when you do toric IOLs that your rexus is central, it is as circular as possible. A very decentered rexus can decenter the lens, squeeze it one way or the other and twist and turn it. A very large rexus also can do the same thing. It can fibrose in the edges and the lens can be squeezed out. Not out of the back, but out of the alignment. A very small rexus also can cause capsular phimosis, and the same issue can happen. So it becomes suddenly very critical to get a good centered, good sized rexus when you're putting toric lenses. The lens has to go into the bag. The bag has to be inflated because you're going to turn the lens in the bag. And please do use cohesive viscoelastic when you are implanting the lens in the bag. Do not use HPMC because you need the bag to be emptied of all viscoelastic end of surgery for the bag to collapse and the lens to become sticky and stay put. So if you want to evacuate it totally easily, cohesive viscoelastic is the way to go. Anything else is going to be very difficult. Remove viscoelastic completely from the AC and from the bag, particularly from behind the lens. The lens has to go and touch the posterior capsule and continue to touch the posterior capsule in the immediate postoperative period. Final positioning should be done under BSS. So axis marking, so I've told you that already. The incision that you are going to do should not induce any astigmatism, stay as small as possible. Most of these lenses, toric lenses, now go into a 2.2 to 2.4 incision. A couple of the companies usually write down to 1.8, both Zeiss and Boya can go through 1.8. Try to keep your incision as square as possible. The incision is ideally placed temporarily to induce the least amount of surgically induced astigmatism. If your SIA is 0.3 or lesser, you can just feed that in and put your incision as to wherever you want to choose the placement. lenses ideally should not be lost. If you've lost the lenses, then you have to rethink whether you're going to put a toric IOL in that particular patient. When you've got the lens in the bag, if most lenses except the Zeiss, so the plate haptic, they can be only rotated in the clockwise direction. So rotate clockwise, stop about 10 to 15 degrees before the intended positioning, then come out, take out the viscoelastic totally, and do the final positioning under BSS. When you reform the chamber, do so very gently. If you aggressively hydrate the wound and reform the chamber very fast and push in a bolus of fluid into the anterior chamber, this bolus is going to go behind the lens, lift it up. The bag is going to get blown up. We don't want that to occur. As the chamber is being reformed, please look at the lens. If the lens is floating up, go back and tap it down. So you would probably end up making the anterior chamber a little less tighter than you would do for a normal lens in a toric IOL, because you don't want the lens to float up. Tap down the IOL endo procedure, please remember that. So video here, I've got two videos. So here's one that was going to the 175. I've got the 180 and 175 mark with a needle. You can see the needle mark. I use the trypan glue to make the mark thin and long. So it will go into the pupillary area so that you can avoid parallax error. If your markings are going to be in the periphery, you can have a parallax error. Rexus has to be as central, as circular as possible. Just a time I skip through the regular phaco part. You remember that the bag should be completely emptied and free of all cortex in all the areas, because if you leave a small amount of cortex in one part of the capsular bag, that part can contract unevenly and cause displacement of the IOL later. So take care that the bag is completely empty. This lens is the upper lens, is a preloaded lens, which can go through a 2.4 comfortably. Goes in. This is under cohesive viscoelastic. Turn, you can see the marking there. And the marking is about 10 degrees short. You can stop. And then take the viscoelastic out, particularly from behind the lens. The bag has to be completely empty. That's very important. And then do the final positioning. Now you see the importance of the line being long, so that there is no parallax error. You really get the accuracy that much better. So that's perfect on the dot. Maybe another video. Here I'm showing you the marking also. This is at 90 degree. The patient is placed. Unfortunately, my hand is in the way, you can't see the marking, but I'm making the mark using the needle with the slit being vertical. And the marking has been highlighted already on the table. So the rest of it is similar. Here this lens is preloaded again. As Dr. Atik said, it has got the haptic tips are made of PMMA, giving it some kind of advantage. Doesn't stick to the lens surface and apparently prevents unwanted rotation. Towards the back. Again rotate and stop about 10 degrees short, as you can see here. Just 10 degrees short, and take the viscoelastic out. At this point, this is the marking, and that is the lens mark, that is the intended positioning of the lens. So take the viscoelastic out again. Remember to go behind the lens, take the viscoelastic out fully, then do the final positioning. Here I actually overshoot about 5 degrees and go beyond. You can probably rotate anti-clockwise a few degrees. You can take the risk of doing it, but if you've gone too far, please go back all the way around. Don't attempt this. It's just about 5 degrees off, so I just re-rotate it being a hydrophobic lens, probably not fully unfolded yet, and I'm able to get the positioning well. But this is not something that I would advise you to do, particularly if you have gone off more. This is absolutely online. So accuracy can be achieved if you just apply basic principles and you're on the dot. So just have few slides on verification of this. So how do you verify? You can verify by refraction, immediate post-op. The moment you finish surgery, you can have a policy of taking the patient on the slit lamp, and with the pupil still being dilated, look for the axis of placement of the lens by placing the axis in line with the marking and read off from the slit lamp as to what is the axis. If the axis coincides, absolutely fine. If it is off by a couple of degrees or 3 degrees, leave it alone. If it's grossly off-center, then you can take the patient back immediately to the theatre and reposition the lens. Probably that rotation occurred because the bag was hyperinflated immediately after surgery. Eye trace is brilliantly useful in this. You can take the patient back immediate post-op, put them on the eye trace and tell you how many degrees you're off. What gives the rotation stability? One, the size of the bag. Two, design of the IOL, size of the rexus, and the bag being either inflated or collapsed. If grossly they are not in alignment, re-rotate instantly. What happens if you are seeing this in the immediate post-operative period? The patient comes to you the day after surgery or a week after surgery and the lens is rotated. Post-op rotation again can be because the bag got inflated post-operatively, or since the bag size and the lens size are not matching each other. In this situation, don't be in a hurry to go back and re-rotate the patient. Wait for 2 weeks or even 20 days. Then wait for the bag to shrink a bit. The shrinkage starts to become sticky. Then take the patient back to the theatre and do the final rotation back at the position. You probably will not need to rotate again. So one, if you see a grossly unaligned lens, immediate post-op, a few minutes after surgery, take the patient back to theatre, re-rotate, empty the bag totally. If you see it a day or two later, don't be in a hurry, wait for up to 2 weeks or even 20 days, then do your rotation. Then your chances of being more accurate and not having to redo the rotation again is much higher. So in summary, toric IOLs are very accurate in correcting corneal astigmatism. Incorporating toric IOLs needs very simple modification of surgical technique, and it can be achieved by any one of us with existing equipment that we have without adding anything to our armamentarium. Thank you.